I am going to just share my screen quick a minute. Sorry, Rachel, we'll have to have you redo that. I'd like to share my screen and show you just a quick little tutorial on what we have on the AHAP website, especially for those that might be new to AHAP. So one of the things I wanted to point out is if you click on the events tab right here, you should see our upcoming events, and you can click on any of those to register. Here's the little register button. If you're interested in our conference that's being held in Orlando, registration is open, so if you click on that link, you should see the information. I know that the agenda is going to be released within the next couple of days, so keep an eye on and check back often for that agenda if you're looking for it. There's also links to the hotel, the conference hotel, and there is a discount on rooms right now for all of the conference attendees. We have an e-magazine that gets published every quarter, and you can access that right here just by clicking on this tab. These are for submission of an article, or if you're a company that would like to advertise within the magazine. So we also have a pretty extensive library, or a resource center and library. Product library is our vendor partners. Our resource center is not found right now. So we'll work on that and get that going again. But that is a very good resource normally with all of every link that you can imagine and the things that we think are useful in helping a preparedness professional do their job. Another thing I'd like to point out is that we do record all of our webinars, and they are located at the tab that I just clicked on. So under members, this tab won't show up unless you're logged into your account. So once you are logged into your account, you'll see this tab. And if you scroll all the way down, you'll see webinar recordings. And if you click on that, you should be able to access all of the recorded webinars that we've done since we've begun the association. So all of that information is listed there, and I just wanted you to know that you have access as a member to all of these things. We also have a mentorship program. We have discussion boards that I would love to see people utilize more heavily. They're not being utilized as much as they could be, and I think they could be a very, very helpful resource. We list our partner events here. So like I said, there's just a lot of resources within our website, and we're always putting new things. Within the AHAP shop, we have some t-shirts and some things that are AHAP branded if anybody's interested in that kind of stuff. So be sure to take a look and check out our website. We're hoping to revamp our Career Center and get make that a lot more beneficial to you as well in the upcoming months. So just wanted you to, as we get started, know of all of these options and resources. So that being said, Rachel, I'll let you take my screen back. So you go ahead and share your screen again. And in the meantime, I'm going to introduce Rachel. Rachel Lookadoo is a JD, and I actually happened to get the privilege to work with her. She is the Director of Legal and Public Health Preparedness at the Center for Preparedness Education at the University of Nebraska Medical Center. In that role, she conducts emergency preparedness trainings and assessments for public health departments and healthcare facilities, and specializes in assisting healthcare facilities in implementing the CMS emergency preparedness regulations. Prior to joining the Center for Preparedness Education, she worked in regulatory compliance for a long-term care and PACE provider. She is an attorney by background and has written book chapters and legal guides regarding topics such as isolation and quarantine law and other legal concerns that arise in disaster response and recovery. So, Rachel, you are clearly an expert on the topic at hand, and I, for one, am very much looking forward to what you have to teach us. So I'm going to turn the microphone over to you and let you get started, and we'll
Sounds
take
good.
questions at the end.
All right, well, thanks, Christy, and welcome everybody to the 2019 CMS Updates webinar. Thank you to Christy and AHEP for putting this on, and thank you to you guys for giving up your lunch hour to hear about CMS. I think this is an area that's brought up a lot of questions, so I'm hoping that we can address most of those today. But if anything comes up while I'm talking during the webinar, just make a note of it or put it in the chat box, and we'll definitely have time at the end to address any questions. So as Christy said, I am Rachel Lookadoo. I work for the Center for Preparedness Education here in Omaha at the University of Nebraska Medical Center. I am an attorney, and I, as Christy mentioned, used to work for a long-term care and PACE provider, and my main task for them was really implementing these regulations. So I feel very familiar with them. I've worked with them quite a bit. But above that, I recognize some of the struggles that come up for facilities when they try and put these regulations into practice. So if you ever have any questions on implementing the CMS regs, here's my email address. You're always welcome to contact me. So I wanted to start with a little bit of background on the EP rule. You may be familiar with some of this, but just for a little bit of an overview. So in November 2016, CMS released the final rule of the emergency preparedness regulations, and they gave providers a full year to implement the regs and get into compliance with a deadline of November 15, 2017. So we're coming up on 2 years that these rules have been in effect. So most of you have probably already gone through some survey for this. You are likely pretty familiar with the rule, but if you're new to this world and these are all new to you, that's okay too. So the way CMS enforced these regulations was to make them a requirement and a condition of participation in Medicare and Medicaid. So any facilities who participate in Medicare and Medicaid can only get reimbursed for those services if they implement these requirements. They made these rules apply to 17 different provider types, and it's a pretty big range. I'll read them off real quick, but those providers include ambulatory surgical centers, clinics, rehab agencies, and public health agencies as providers of outpatient physical therapy and speech pathology services, community mental health centers, comprehensive outpatient rehab facilities, critical access hospitals, end-stage renal disease or dialysis facilities, home health agencies, hospices, hospitals, intermediate care facilities for individuals with intellectual disabilities, long-term care facilities, organ procurement organizations, PACE programs, psychiatric residential treatment facilities, religious non-medical healthcare institutions, rural health clinics and federally qualified health centers, and transplant centers. So you can see from that list, it's pretty inclusive. Basically, if you're not sure if these rules apply to you, if you get Medicare or Medicaid funds, they probably apply. So why these regulations? What brought them about? Essentially, after Hurricane Katrina, 9/11, H1N1 pandemic, some of the flooding we had in 2011, there were a few other major named disasters. It just became really clear that here in the US, we needed better organization and response plans for healthcare facilities to deal with emergencies. It just wasn't something that we were doing very well. So Hurricane Katrina was an especially staggering example of this. There were multiple incidences of patient casualties where facilities just did not have a plan in place for evacuation or for providing for the needs of their patients in an emergency. So I've included these pictures here, and this is actually from a long-term care facility in New Orleans that when Katrina hit, they just locked their doors. They had no plan for evacuating. They kept everyone inside, and I believe most, if not all, of their residents were killed in the storm. So this was a really horrifying example that made everyone sort of take a step back and realize we need to have some better plans in place. And that's continued to be an issue. So as we saw in 2017, we had Hurricane Harvey and Hurricane Irma that were devastating in Texas and Florida. And we ended up with this picture that I would say is now infamous of an assisted living facility that failed to evacuate and instead had these residents just living in floodwaters, which is not ideal or good at all for anyone. Additionally, in Florida with Irma, there was this nursing home that I've got the headline from here where residents died because the nursing home did not have a plan for how to power their AC using an alternate energy source or a plan to evacuate. I think that story is especially heartbreaking because I believe, if I have this correct, there was a hospital very close to that facility that had power that could have provided an AC to those residents. So clearly this is an area where there's still a lot of work to be done, but I think CMS's hope is that by implementing these regs, these kind of incidents will be much less frequent, and facilities will be way better prepared to make sure these sort of things do not occur. So let's get into the content of the rule. So the EP rule requires all affected providers to implement an emergency preparedness program, which consists of 4 main components: risk assessment and planning, policies and procedures, a communication plan, and training and testing. So you're probably familiar with these components, but I just want to give a brief review of all of them, and then we'll get into the interpretive updates from this year. So the first component is risk assessment and planning. And CMS intends for all risk assessments and emergency plans to take an all hazards approach. They're really big on that concept. All hazards you're going to see throughout the regulations. So this means that a risk assessment must consider any possible risks that may occur in the geographic area surrounding the facility. So this can range from natural threats like severe weather to man-made threats such as cybersecurity or terrorism, to a facility-based threat such as a power outage or a chemical spill. So when a facility is doing their risk assessment, they don't need to include every possible hazard under the sun. So for example, I live here in Nebraska. Healthcare facilities here are not going to be including hurricanes in their assessment. It's whatever is relevant for your area. And it just needs to include that sort of broad spectrum of possible hazards or threats in the area. I think CMS's intention is that by including such a wide range of possible hazards, facilities are better prepared for any possible emergency and won't be caught off guard by a random type of threat. They're going to be a little more ready. So facilities are going to take that all hazards approach and begin to create an emergency plan that is tailored to their unique needs and concerns. So before creating a plan, the facility needs to begin by conducting a facility-based risk assessment. So you may have heard these called hazard vulnerability assessments or HVAs as well. I know quite a few facilities have used, there's a HVA that Kaiser put out that's been really popular, and I've seen a lot of facilities use that HVA. However, I think it's worth noting CMS does not prescribe any specific format or template or specific risk assessment to be used. That is completely at the facility's discretion to determine which assessment they want to use. So you're not required to use that Kaiser HVA just because everyone else is doing it. It's just been a popular choice, but you're welcome to use any risk assessment you think would be best for your facility. So after that risk assessment is completed, the facility will then take the results and create their emergency plan. So the plan is composed of the other named components that we mentioned before, and it provides the framework for how the facility will respond to an emergency. And importantly, it also addresses how they will maintain continuity of business operations. That needs to be one of the primary focuses of a facility's emergency plan. How are they going to continue to provide medical care to their patients? So the plan and the risk assessment has to be reviewed and updated annually. So this means that that risk assessment needs to be conducted every year. I think kind of a best practice for facilities is if you know, okay, April is the month we do our risk assessment, and just make it the same time every year so that your staff knows when to expect it. Everyone knows this is the time that we do our risk assessment. So the next component are the policies and the procedures. And these really serve as the meat of the emergency plan. This is where all the specific details of how a facility will operate are delineated and outlined. The required policies and procedures differ a little bit between the 17 provider types, but for the most part, they have to include policies and procedures for evacuation, sheltering in place, providing for subsistence needs, which includes food, water, power, etc. It needs to include policies for a HIPAA compliant system for medical documentation, using volunteers, and tracking patients and staff. So again, there's more detailed requirements for each provider type, and there's some differences in there, but overall, those are the high-level policies that are generally required for everyone. And this is the same as the plan and the risk assessment. The policies and the procedures must be reviewed and updated annually. So again, it may be worthwhile to have 1 month of the year is your emergency preparedness month, and that's when you just go through and review and update everything. Next up is the communication plan. So the communication plan really gets into the detail of how a facility is going to communicate both internally and externally in the event of an emergency. So from an internal perspective, facilities need to account for how they'll inform staff, patients, volunteers, providers, and any other relevant individuals about an emergency at their location. From an external perspective, the communication plan needs to address how information is going to be disseminated to the public, including to press, outside community organizations, and patients' families. Specifically, if you're in a long-term care setting, you want to make sure your residents' families are informed of any type of emergency at the facility. Additionally, the communication plan needs to focus on how to coordinate patient care across the facility and in the event of a transfer to another facility. So in looking at that coordination of patient care, HIPAA comes into play. So in your communication plan, you need to make sure you're addressing how you're going to maintain HIPAA compliance throughout an emergency. So sometimes in a federal emergency, HIPAA sanctions can be waived temporarily. But generally, in most situations, you need to make sure HIPAA requirements are being followed at all times throughout the duration of an emergency. So the more you can plan for that ahead of time, and the more you can include language in your communication plan that explains how you're going to address the HIPAA requirements, the more protected you are later from any private liability or from any government sanctions or fines. And so again, with the communication plan, just like with the policies and procedures and risk assessment, they have to be reviewed and updated annually. So affected providers have to develop a training program for staff, both new staff and existing staff, and also for volunteers. Again, some of the 17 provider types have to also provide training to other individuals, such as contracted providers, patients or residents families. So if you're not sure who you need to be training for these requirements, just look at the regs and they'll break it down for each provider type. All the provider types, though, have to provide training on the emergency plan and policies to new staff at the time of employment. So make sure, any new staff you have probably has to go through some level of training, probably some HIPAA training, some safety training. Include your emergency plans in that initial training. Otherwise, training needs to occur every year for all staff. And this needs to be documented. So whatever training occurs, you need to make sure you document when it occurs, who received the training, and what they were trained on. This is really critical. The main purpose of this requirement is one, so your staff knows what to do in an emergency, but also think about if you have a surveyor come into your facility and they stop a random member of your staff and ask what they would do in an evacuation situation, you want that person to be ready with an answer and to be able to answer the surveyor's questions. So make sure all staff knows what their role is in an emergency and your basic emergency plans. So in addition to the training element, providers need to test their plans through the use of exercises. So by conducting exercises of their emergency plan, providers can be better prepared for any possible surprises that may show up in the midst of an emergency. So CMS requires that providers conduct 2 annual exercises. One needs to be a full-scale community-based exercise, and then the other can be of the facility's choice. So that can be another full-scale, or it can be a tabletop exercise. And I just want to review, the community-based full-scale exercise has to involve broader community engagement. So you should be working with EMS, other healthcare providers in the area, other community emergency response agencies, in developing and participating in that exercise. So CMS's goal with this requirement is to help facilities establish better connections with their communities. I think this way, if there's a real-life emergency, you've already established a relationship with these community organizations, and it'll be much easier to access them. Plus, those organizations will have at least some awareness and familiarity with your emergency plan and can probably better serve you in that incident. If you as a facility try to conduct a community-based full-scale exercise and cannot get any engagement from community organizations and are having a hard time getting anyone to respond, I know that's happened with a lot of different facilities, then CMS does allow you to conduct a facility-based exercise instead. If that happens, I would be really careful, though, to make sure you document any efforts you made to engage community organizations. You know, if you can show an email that you reached out to EMS and tried to get them to participate in your exercise. Anything along those lines, any communication showing that the community organization would not participate, I would keep that documented just to better protect you in case the question comes up at survey. So one important caveat on this requirement is if a facility activates their emergency plan for a real-life incident and adequately documents that response, whether that's through an incident report or a written after-action report, then they are exempt from the community-based full-scale exercise requirement for 1 year following the event. So anytime your emergency plan is activated, make sure you are documenting that, writing up an after-action report, and keeping a good record of it, because that way you can be completely exempt from that requirement to have the full-scale community-based exercise. So let's get into the updates that occurred this year. So all of the updates we received this year were provided through the Appendix Z document. I don't know if you're familiar with this document. If you're not, I would really encourage you to take a look at it. So this is the, I believe it's the State Operations Manual is what they call it. And Appendix Z provides interpretive guidance and surveyor procedures for all of the CMS emergency preparedness regulations. I think this document is just extremely useful. It breaks down the regulations into much more understandable terms and explains more explicitly what CMS is looking for. I think sometimes when we look at just the regulations, it's easy to try and interpret them and figure out what CMS was meaning. And with this document, it's already done. So you can just read through that and get a better idea of what a surveyor is going to be looking for when they come to your facility. So in February of this year, CMS released an updated version of Appendix Z, and it had some significant substantive guidance changes, but there were also some minor corrections as well, including changed citation numbers, mostly for home health agencies. One of the main things that CMS added to the interpretive guidance was a broadening of the definition of all hazards planning. I think this has been kind of the most noticed change that they made this year. So as we talked about before, facilities have to do this risk assessment and create their emergency plan based on an all hazards approach. So in Appendix Z, CMS expressly identifies the types of hazards that need to be included in that all hazards planning as natural disasters, man-made disasters, facility-based disasters, and then the new addition that they put in this year is emerging infectious diseases. So this has been a big change for a lot of facilities. It's not an area that some places have been familiar with. So I think there's been a lot of confusion and concern over how to address this new addition. So let's take a look at it in a little more detail. So emerging infectious diseases, or EIDs, as you may see them called in the regs, are only mentioned in Appendix Z. They are not specifically outlined in the requirements, they're just in the interpretive guidance. So in that guidance, CMS mentions Ebola, influenza, and Zika virus as examples of potential EIDs, but they're careful to say that any planning should be broad and cover all possible EIDs. It's not that CMS wants you to specifically plan for Zika or Ebola. They just want you to be aware of the issue of emerging infectious diseases. So CMS's intent, they've stated this in other places, by including this new requirement was to give infection control a better seat at the table for emergency planning. I think facilities may not have previously included their infection control staff or their infection preventionist in their emergency planning. So this requirement and guidance gives facilities a chance to rectify that and bring those groups to the table as they create their emergency plans. So by including these EIDs in their risk assessment, facilities can determine that they might need to change or update some of their policies. And those policies could be about things like isolation measures or personal protective equipment, which you'll see referred to as PPE frequently. So these policies are not required. CMS is not asking you to create any new policies. It's at the facility's discretion to determine after their risk assessment if they need to put those type of policies in place. I know for some facilities, the concept of personal protective equipment may not be something they're as used to, so this may be unfamiliar ground. So it just needs to be at your discretion whether this is something that you need to strengthen or modify for your facility. So one of the other major additions to the interpretive guidance was some clarifying information about the requirement for facilities to have, and I'm going to quote the reg here, an alternate source of energy to maintain temperatures to protect patient health and safety and the safe and sanitary storage of provisions, as well as emergency lighting, fire detection, extinguishing and alarm systems, and sewage and waste disposal. So, per Appendix Z, there is no requirement that facilities update their existing alternate energy sources. It's only after they've conducted a thorough risk assessment, if they think that they need to change their alternate energy sources, then they may do so. But that is, again, at the facility's discretion and determination whether they think that needs to occur. So I think it's important to note that we can see kind of throughout this interpretive guidance that CMS puts a lot of value on that risk assessment. So they're trusting facilities to conduct a really thorough and facility-based risk assessment so that they can determine what policies need to change. So facilities have a lot of leeway to determine what is right for them in adapting these policies. So CMS goes on to encourage facilities to collaborate with their local healthcare coalition and emergency management organizations to find potential alternate energy resources in their community. So by connecting to those groups, you might find that there's a larger pool of resources available, a larger source of alternate energy sources, and that you can better utilize your time, money, other resources by connecting to these broader groups. I'd really put in a plug here for your healthcare coalition. If you have not yet connected with them, they're a great resource to you. They can help you with things like this, like finding other resources in the community, but also as you conduct your community-based exercise, your healthcare coalition can help connect you to some of those community organizations that should be a part of that exercise. So CMS made some other clarifications regarding the alternate source of energy requirements. So the regs state that an alternate source of energy must be available to maintain a temperature for patient health and safety, as well as safe storage of provisions. But this does not mean that you are responsible for maintaining an even temperature throughout your entire building or facility campus. That temperature only needs to be maintained in any area where patients and staff are housed, or any area where provisions like food or water are stored. So I think that's important, especially as you come up with your sheltering in place policies. You don't need to be heating and cooling your whole building. If you're only sheltering in place in certain areas of your building, then that's where you need to focus all your energy for maintaining temperatures. I think this kind of relieves some of the burden on providers to try and come up with a source of energy that's big enough to take care of just these areas. You don't need to make it so big. So additionally, Appendix Z outlines specific requirements for the use of portable generators. I am not going to go through all of those here because I don't know if that's the most fun way to spend your lunch hour hearing about portable generator rules. But if you are concerned about what rules need to be followed in terms of using portable generators, take a look at Appendix Z. It outlines all the specific requirements for those generators. If you're using a portable generator, for example, some of the life and safety code requirements that may normally apply would not apply. So just take a look at those if that's the route you're going for your alternate source of energy. One item I did want to specifically call out is CMS explicitly states that extension cords cannot be used to connect electrical devices to a portable generator. Now, I know that extension cords are generally already forbidden in most healthcare facilities, but I just wanted to make sure it was clear that even in an emergency, when you're using a portable generator, no extension cords can be used. So just as a rule, keep the extension cords away from your facility. So within this same section, CMS provided some additional clarification relating to the broader subsistence needs policy. Because again, that alternate source of energy falls under the subsistence needs umbrella. So for one thing, there's no specific recommended mechanism or process from CMS regarding how to manage sewage or waste disposal. That is, again, completely at the discretion of the facility. The only requirement from CMS is that the facility has a policy in place that outlines and addresses how the facility will dispose of waste and sewage and what alternate energy source they'll use to do so. I have another thing on here, and this is just something that I have seen a lot. I think this has been a source of a lot of confusion. I've heard a lot of people talking about how much food or water they're expected to provide on site at their facility. How much do they need to keep stored up? This has been really confusing. I know some people have said you need to have 48 hours worth of provisions, 72 hours. I've heard a lot of numbers thrown around. So I want to point out Appendix Z, which is the CMS issued interpretive guidance, states that there is no set requirement or standard for the amount of provisions such as food and water that needs to be provided in the facility. So there may be outside requirements like Joint Commission or other licensing or governing bodies who have a different stance on how much provisions you need to keep in your facility. But please know from a CMS perspective, that is at your discretion. They have no time requirement, no set amount of provisions that need to be kept. So you have some flexibility in determining what your specific needs would be in an emergency situation and how much food, water, etc. you need to keep on site. So I just want to clarify that. I think there's been a lot of misinformation out there. So again, from a CMS perspective, there's no set requirement. So I do want to clarify one quick thing. The last 3 slides, so where we've been talking about alternate sources of energy and subsistence needs, only apply to these provider types. So religious non-medical health institutions, inpatient hospice, psychiatric residential treatment facilities, PACE programs, hospitals, long-term care facilities, intermediate care facilities for individuals with intellectual disabilities, and critical access hospitals. So the other provider types are not included in these requirements or updates. I think if you look at that list, these are, I think, almost all inpatient programs. So those outpatient facilities do not need to worry about these requirements. This is strictly for the inpatient facilities. So there was some additional guidance given in Appendix C regarding evacuation as well. So this guidance states that in the event that a facility is in an area where the state or local community has issued a mandatory evacuation, then any affected provider in that area must abide by and follow any state or local mandates. So this is just my opinion, but I would guess that that guidance was put in place as a response to the 2017 hurricane season, where we saw some of those incidences where facilities disregarded or ignored local mandatory evacuations. I think this is just an attempt to tell facilities, listen to what's going on in your community. If there is a mandatory evacuation, you should also follow that evacuation. So the next piece of clarifying guidance is a little bit of a random one, but still an important one. And this relates to the training requirement for contracted providers. So CMS acknowledged that there's probably going to be some individuals who contract at multiple facilities in a given area and probably cannot feasibly receive formal emergency preparedness training at each facility. So for these type of contractors, and only these type of contractors, this does not apply to any other staff, facilities can make a determination of how they'll deliver training on that contractor's role in an emergency and on any relevant emergency policies or procedures. Regardless of how they provide that training, they still need to document it, and they must still give enough education that the contractor is able to answer any survey or questions about their role or any relevant plans or policies. So the final piece of updated guidance is an especially important one. So this relates to the testing and exercise requirement, and I think this is going to be a huge help to any facilities who have been significantly impacted by emergencies in a given year. So the new guidance states that if a facility activates their emergency plan twice in 1 year and adequately documents it both times through the use of something like an incident report or an after-action report, then that facility is exempt from both exercise requirements for 1 year following the actual event. I think this is a fairly significant change because before it was previously, if you've activated your plan once, you are exempt from the one full-scale exercise. But now they've changed it. So if you activate your plan twice, again, you are exempt from both exercise requirements for 1 year following the emergency. So I wanted to review a little bit some trends I've seen in e-tags that were given on survey. This is purely from anecdotal things I've been told by other providers or individuals at meetings or conferences, but there have been some e-tags that seem to occur with some frequency. So first off, documentation of training. I think this can be an easy one to miss, but providers need to be really careful that they're keeping a written record of who has received training on their emergency plans and when that training occurred. That can be as simple as a sign-in sheet but just make sure you're documenting who is getting trained and when. Next one's the completion of both exercises. Granted, we just talked about how there may be exemptions in the event of 2 emergency plan activations, but generally, facilities need to conduct both a community-based full-scale and a separate second exercise. So these exercises need to be documented with an after-action report to demonstrate that facilities are trying to find a way to improve and strengthen their plan after their exercise. So that documentation of the exercise, including the after-action report, needs to be readily available and accessible when the surveyor comes to the facility. So the third area of tags that I think has been the source of quite a bit of confusion is 1135 waivers. I think realistically, we could probably do a whole other webinar strictly on 1135 waivers, but I want to just give kind of a brief review of them. I think this is an area that, a lot of facilities probably didn't have much interaction with prior to these regulations. They may not understand, it may be a totally foreign concept. And so it's been hard for some facilities to come into compliance with this requirement, and so they've been cited for it. If you recall from the regs, which you may not, and that's okay, there's a requirement for every provider type to have a policy and procedure in place relating to how they will handle the 1135 waiver process or the use of an alternate care site. So that's where this tag comes into play. So 1135 waivers can only occur in a very specific circumstance. Only when the President has declared a federal emergency and the Secretary of Health and Human Services has declared a public health emergency. So if both of those conditions are met, the HHS Secretary can choose to activate 1135 waivers. And what these waivers do is they can temporarily waive certain Medicare or Medicaid requirements in order to be sure that adequate and sufficient health care services are available to Medicare and Medicaid eligible individuals in the emergency area. So these waivers also make sure that providers who provide these types of services can still be reimbursed by CMS for them, and also that they can be exempt from any sanctions in case they are unable to meet the requirements. So the types of laws or regulations that may be covered under an 1135 waiver include HIPAA sanctions, EMTALA sanctions, Medicare conditions of participation, and other federal laws or regs. So I want to make that very clear. 1135 waivers do not and cannot apply to state laws or regulations. State laws and regs are normally where you have a lot of your licensing requirements. So just keep in mind that state laws and regs can only be waived at a state level by the governor in most states, but an 1135 waiver will not affect a federal requirement. In the same way, a state level emergency declared by a governor cannot waive federal laws. So an 1135 waiver will only come into play when it's a federally declared emergency. So I've included a graphic here from CMS, and this is some of the questions that are asked during the 1135 waiver process. So in order to obtain an 1135 waiver, healthcare facilities that are affected by an emergency should contact their CMS regional office or their state survey agency and request a waiver. So in that request, the facility needs to include an explanation of the need for the waiver request and an anticipated duration of time needed for the waiver to be in place. So these waivers are always time specific. They typically, I think, last either 60 days or until the termination of the emergency declaration period. But they're not ambiguous, they don't go on forever, it's for a very limited duration of time. Once the regional office or state survey agency has this information, then they can assist in making a determination of whether a waiver would actually address the needs mentioned by the facility and whether it would be beneficial to issue that waiver. Sometimes they can decide to either issue an individual waiver to just a facility or a blanket waiver, which will cover all the facilities in a given geographic area. So for our purposes, for the CMS requirements, providers have to have a policy or procedure in place demonstrating their awareness of the 1135 waiver process. So for whatever reason, I've heard a lot of providers interpret this to mean that they need to have an 1135 waiver on file and that they need to just keep that on file. So this is not actually possible to do. 1135 waivers are time specific. They're unique to a given emergency. There's no way to get them ahead of time. They are unique to the moment. So if you hear someone saying that in order to meet the regs, you need to have a waiver on file, that's not a thing. That's not something you have to do. You just have to have a policy in place showing that you know what the process is and that you have a process for how you will contact your regional office or state survey agency. Another thing that I think has been a question is whether there is a set or prescribed form or template in place that CMS would prefer providers to use. And there is not. So facilities do not need to worry about using any specific type of form or template. It is at their discretion how they provide that information to the state survey agency or the regional office. So before we close, I just want to briefly touch on this. There's been some proposed changes to the regulations that CMS released for comment last fall. So these have not been adopted yet, but CMS did release them as proposed changes to try and ease the burden of the requirements on providers. So the changes, there's a bunch of them. Some of them are really small bureaucratic things, but two of the main ones are the changes would change the annual program review to occurring every 2 years rather than every year. So the reasoning there is that most facilities are not going to experience enough changes in one calendar year to justify a full update or change to their plan or processes. For the most part, those policies and procedures are going to stay consistent over a year. So this would potentially change that review requirement to every 2 years. The other major change would relate to the testing and exercise requirement for providers. So this would allow outpatient providers to only have to conduct one testing exercise a year, which would be a big change. So again, I just want to point out these are only proposed changes. They have not been adopted or formalized, but they were open to public comment during last fall. I think the comment period ended in November of 2018. So hopefully this year we'll have a better idea if CMS chooses to adopt any of those changes. So if you're still with me, I'd like to open it up to questions. I'll check the chat box, and Christy, if you have any that I didn't get, let me know. But are there any questions that anyone has relating to today's presentation?
Thank you, Rachel. Excellent presentation. I just learned so much. I can't believe it. So I want to invite people to chat questions in the chat box, or if you want to unmute yourselves and ask through the web software, that is fine with me as long as you have a microphone.
Christy, I did get one question on chat. So
Okay.
I had a question here about we're a surgical hospital that has overnight patients. We also have urgent care under our umbrella. Does the rule apply to the urgent care? So unless the urgent care is licensed as one of the 17 provider types that I mentioned at the beginning, the rule does not apply. The hospital obviously would be covered, but the urgent care, unless it's licensed differently, it would not apply. So that really comes down to how the individual facility is licensed. So that was one question, but let me know if there are any others.
So to clarify that question, so when you say licensed differently, so if the urgent care is under the hospital license that would be required? Like if the urgent
Yes, if the urgent care is included within the hospital licensure, then it would be covered under these requirements. But if the urgent care has a separate licensure and it is not licensed as one of the 17 provider types, then the rule would not apply. Okay. Does that make sense?
Yeah, it makes sense to me, hopefully. And if somebody else needs to be any clarification, that's
So I
good.
just got another question. Does the guidance document identify the new changes that took effect, or do we have to search for them? So the nice thing is this document, they put all the changes in red. So it's really easy to see where the new guidance is. And I put pretty much anything that was in red was in this presentation. So if you have any questions about what was included, look for Appendix Z. I believe the document was released on February 1st, 2019, and any of the red text is the updated information. Okay, and looks like we have another one. How might the new rule about EIDs apply in an outpatient hospice setting? So again, about the EIDs, the emerging infectious diseases, it's not necessarily a new requirement, it's just something to keep in mind for your planning. So as you're creating your emergency plan for your outpatient hospice, what you need to do is just make sure when you're conducting that risk assessment, look at what if we have a patient come into our hospice who has Zika or Ebola or a different emerging infectious disease. What would we do differently? Would we be adequately prepared to address that? Do we have isolation measure policies in place? Do we have a specific room where we would put that patient? Do we have personal protective equipment readily available for staff or patients? CMS did not give a lot of specific requirements on this, so it's still pretty broad and open to interpretation. But I would say the rule would apply just in as you're doing your risk assessment, take a look at how ready you would be if someone with one of those diseases presented in your hospice or your facility for everyone else.
And one thing I wanted to add to answer that question, a great resource online that is available for free to anybody is on www.netech.org. That is the collaboration between the 3 facilities in the U.S. that actually cared for Ebola patients, and they have written tabletop exercises, written full-scale exercises that you can basically pull from, print them, and use those as resources. I'm not sure how many actual policies and procedures are on that you could adapt to your own facility, but there are a lot of resources regarding PPE and what's appropriate for what illness and everything in between. So again, it's www.netec.org. It's a great resource and it's free. It was funded through ASPR, the project. So Rachel, do you have other questions that you have to
I just got one more. So as a follow-up to the urgent care question, what would differentiate the urgent care clinic from the clinic type in the 17 provider types? So just to clarify on that, clinics as a broad overall term is not included in the 17 provider types, and I apologize if I made it sound that way. So clinics are only included if they are clinics who serve as providers of outpatient physical therapy and speech language pathology services, or if they are rural health clinics or federally qualified health centers. So clinics as a general broad term is not listed as one of the 17 provider types. Now, I would say with that said, if the urgent care clinic is separately licensed as a clinic, it's not considered part of the hospital. If that's the case, and if these requirements do not apply, I would still argue it would probably be a best practice to still probably implement some of these rules as they relate to the hospital, since you're all in one campus, one facility, for your clinic, even though it's not a CMS requirement for that provider type. So I hope that helps, but I just think for the sake of best practice and for looking out for your patients and staff, even where these rules don't apply, it probably couldn't hurt to adopt some of the policies as well.
So Rachel, I have a couple of questions of my own, but I wanted to let everybody else get theirs in first. actually only one question. The other one is a statement. I know that you mentioned that 1135 waivers could be a whole nother full webinar.
Mm-hmm.
We'd love to have you back. And secondly, we also have had somebody from CMS talk on 1135 waivers specifically, and that's part of our recorded webinars too. So
Oh, wonderful.
somebody really has a lot of questions on that. Back to my question though, it's an exercise question. So I know you said something about if you activate a plan, and you write it up with an after action report, that counts as one of your exercises. So does it have to be a major disaster that you're activating your plan for, or could it be, it's a winter weather storm? And a lot of people don't really, especially if you're used to that kind of thing, you don't really consider a winter weather storm a big disaster, but it's something that many agencies activate their plan for. So for those little disasters, or a planned air conditioning event that you're going to activate, or a power outage or whatever, that you're going to activate your plan anyway.
Mm-hmm.
If you activate your plan, does that count, big or small, or does it have to be a real?
I believe that still counts. So I have seen facilities who've had, a water outage for a day. They've activated their emergency plan in that situation. Does that seem like the same scale as if a tornado comes through and destroys your building? It may not seem like it's on the same level, but it's still an activation of your emergency plan, and it still counts. I think what it really comes down to is how you're documenting things. So even if it's something relatively minor, such as a winter storm, etc., if you're activating your plan and you can document how you put that plan into place, what processes you changed, etc., that still counts as testing your plan. So I think as long as it's well documented, anytime you're activating your emergency plan, even if it's minor, can still count. I wouldn't try and, game the system too much on that, obviously, but if you're activating your plan, document it, you can count it towards that exercise requirement.
Excellent. Well, practice is practice. I mean, any chance you get
Exactly.
to activate your incident command is really hugely helpful, and if you end up with something that is a real event. So
right. And I would say too, even in those incidences where it may seem like something smaller or something that you're more used to, those realistically are the emergencies that you're probably going to face the most often. So testing them in that capacity is probably even more beneficial, because you're going to deal with small things like power outages or winter weather storms more frequently than you would likely deal with a large scale incident.
excellent. Did you have any other questions that came directly to you, Rachel?
I did not, no, but I did want to put up, here's my contact information. My email address is on there. I'm always available. If there are any other questions that come up or something that you didn't think of today, feel free to email me. I'm happy to answer any questions.
Thank you, Rachel. We really appreciate you sharing your knowledge and expertise on this topic, and we hope to have you back again soon.
Thank
Have a great
you.
day.